Now we are going to discuss sutures and anastomosis. Sutures and anastomosis. Okay. So first we are going to discuss that what are the types of sutures. So sutures can be divided into absorbable sutures and non-absorbable sutures. Absorbable suture means the term is self-explanatory. It is absorbed in tissues because of phagocytosis or enzymatic digestion, and non-absorbable means it is not absorbed. It means it is going to persist in tissues for indefinite period of time. Okay, so see the differences. First, types of sutures. So absorbable sutures and non-absorbable sutures. Non-absorbable. Clear? So first important point, absorbable sutures are absorbed in tissues. Absorbed in tissues because of enzymatic digestion and phagocytosis, right? And non-absorbable sutures, these are going to persist for indefinite period. Okay. Now there is further division that absorbable and non-absorbable sutures are further divided into natural and synthetic. So what are natural absorbable sutures? Chromic catgut and catgut. So catgut and chromic catgut are natural absorbable sutures. What are natural non-absorbable sutures? Silk and linen. Okay. So see, the natural absorbable sutures is catgut and chromic catgut. Catgut and chromic catgut. Okay. And natural non-absorbable suture, and this is silk and linen. Silk and linen. Okay. After that, what are the synthetic absorbable sutures? So synthetic absorbable sutures include polyglycaprone, polydioxanone, vicryl, dexan. And what are the synthetic non-absorbable sutures? Proline, ethylone, nylon, right? This list is important because it is frequently asked, so you have to remember synthetic absorbable sutures and synthetic non-absorbable sutures, right? So synthetic absorbable sutures, polyglycaprone, polydioxanone. Polydioxanone are also known as PDS in short form. Okay, vicryl and dexan, right? Now see, important questions. Polyglycaprone is also known as monocryl. Vicryl is also known as polyglactin, and dexan is also known as polyglycolic acid. You have to remember the names. So polyglycaprone, the other name, it's also known as monocryl. Okay. Vicryl, the other name is polyglactin, and dexan, other name is polyglycolic acid. Simple. So how to remember? The mnemonic is, can you see, PVD. So PVD means polyglycaprone, polydioxanone, vicryl, dexan. So how to remember? The mnemonic is PVD. Now synthetic non-absorbable sutures, proline. What is the other name of proline? It is also known as polypropylene. Second is polyester, and ethylone, nylon. Clear? So how to remember? Here the mnemonic is PEN. So the mnemonic for synthetic non-absorbable suture is PEN. So pen means proline, polyester, ethylene, nylon. Clear? So this is important. After that, sutures are further divided into monofilament and polyfilament sutures. Okay. Now see the difference. In monofilament suture, there is a single strand of fiber, smooth and strong. So if there is a single strand of fiber, this is monofilament. And if in the suture there are multiple strands braided together. So if, can you see, multiple strands are braided together. Have you seen a rope? So you have seen there are multiple strands. So here you can see multiple strands braided together. So in between strands, can you see there is space? And because of this space is known as crevices. So because of this space, what's the problem? There is increased risk of infection. If we see the monofilament sutures, in monofilament sutures, since it is smooth and strong, there is no crevices, so it is associated with decreased risk of infection. But in polyfilament sutures, since there is crevices or presence of space between the strands, there is increased risk of infection. Second problem, monofilament suture. What is the problem? The knots are less stable, and that's why in monofilament sutures we take how many knots? 6 to 8 knots. And in polyfilament suture, the advantage is that knots are more stable, and that's why 3 to 4 knots are sufficient. So see the differences between monofilament and polyfilament sutures. Clear? So monofilament means mono, so there is single strand. So these sutures have single strand, and these are smooth and strong. Smooth and strong. The good thing that since there is a single strand, decreased risk of infection because there are no crevices. So crevices are not there. But the problem, the knots are less stable. So the knots tied become loose. So knots can become loose. That's why these are less stable. How many knots we take? That's why we take 6 to 8 knots with monofilament sutures. If you have seen laparotomy, whenever we are closing the rectus sheath in laparotomy, you have seen the surgeon is closing the rectus sheath with proline, and you have seen that how many knots surgeon is going to take? Generally 6 to 8 knots with proline, and you must be knowing that proline is a monofilament suture. So what are the examples of monofilament sutures? Mnemonic is pen. So we discussed. So here proline, ethylene, nylon. Okay, all these are monofilament sutures. Now see polyfilament. So it's poly, it means there are multiple strands, and these multiple strands are braided together. So these are braided together. Clear? The advantage is that this suture is easy to handle. So this is easier to handle. Another advantage that the knots are stable. Knots are stable. So generally how many knots we take? We take 3 to 4 knots. But the problem that there is presence of crevices between the strands, and because of these crevices there is increased risk of infection. So there is increased risk of infection. Clear? So indirectly this question will be asked that if there is evidence of infection, or we are suspecting that the wound will be infected and we are supposed to put the suture, which one is preferred? To prevent infection, surgical site infection, which suture should be preferred? It's the monofilament suture, right? What are the examples of polyfilament sutures? So how to remember? The mnemonic is slip. Okay, so you can easily understand. S silk, linen, and P is polyglycolic acid, also known as Dixon. So S, that is silk, this is linen, and this is polyglycolic acid. And what is the other name? It's the Dixon. Clear? So it's very easy to remember because you know the mnemonics. Now, if you have seen the trend of or pattern of questions from the last 5 years in AIMS, NEET and in INI CET, you have noticed that almost every year there is minimum one question from sutures, minimum one. And what kind of questions are asked nowadays? These are image based questions. Generally, they give the image of suture or image of packet of suture. And what is the good thing about the packet of suture? That the suture name is already written on the packet, so it's very easy to identify. So one by one we are going to discuss. Let's first discuss the catgut. Now see, this was the image based question in NEET PG. Can you see here? It's written what? It is catgut. So be careful, catgut is not the catgut, it is the sheep gut. Which part of sheep gut? Ileum. Which layer of ileum? It is the submucosa. Okay, so see the questions related to catgut. It is prepared from, first who discovered catgut? John Hunter. Clear? So it is prepared from sheep gut. Which layer? Is the submucosa. So it is prepared from submucosa of sheep's ileum. Generally sheep's ileum. Okay, you know that this is absorbable suture. What kind of? Natural absorbable suture. And if you have opened catgut in the OT, you have noticed that there is a fluid or liquid in which this catgut is immersed. So it is having a preservative solution, having good smell. So why there is preservative solution? Because it is natural absorbable suture. If no preservative will be there, it will be degraded by bacteria. So question, what is that preservative solution used? So it is isopropyl alcohol. Isopropyl alcohol. Clear? This is frequently asked question. So preservative solution is isopropyl alcohol. After that, there are two types of questions asked. One, that tensile strength of suture is lost in, and second, the suture is absorbed in. These two are two different questions. So that's why in exam you have to read the question carefully, that whether in the question tensile strength is lost is asked, or in how many days suture is absorbed, this question is asked. So if you see catgut here, the 50% tensile strength, it is lost in 3 days. So 50% tensile strength is lost in 3 days, and all tensile strength is lost in 15 days. Clear? So this is the question related to tensile strength. Now see the twist. Suture is absorbed in how many days? 60 days. So if the question is asked, the suture is absorbed in how many days? It is absorbed in 60 days. And this is the question which is most commonly asked, that in how many days catgut is absorbed. So it is absorbed in 60 days. Now see, whenever this catgut is tanned with chromium salt to improve the handling of suture and to resist the degradation, this catgut is known as chromic catgut. Okay, chromic catgut. Clear? So it is self-explanatory here. Catgut is tanned with which salts? It is tanned with chromium salt. Clear? And what is the advantage? Why? To improve the handling. It improves the handling. Clear? And it resists the degradation. So it resists degradation of suture in tissue. Resist the degradation of suture in tissue. Now, in how many days tensile strength is lost? It is 21 to 28 days, and the suture is absorbed in 60 to 90 days. So here, tensile strength, it is lost in 21 to 28 days, and the question which is asked, that the suture is absorbed. The suture is absorbed in 60 to 90 days. Now see this suture, it's already written. What's the name of this suture? This is vicryl. And what is the other name of vicryl? It's polyglactin. Now, how to identify this suture? You can see what is the color of this suture. The color of this suture is violet. Okay, and if you see this suture carefully, can you see that there are multiple strands braided together, and simultaneously can you see that there is a space, there are spaces, these are known as crevices. So what kind of suture is this? This is monofilament suture or this is a polyfilament suture. So vicryl is a polyfilament suture. Okay, so it's vicryl. What's the other name of vicryl? It is also known as polyglactin. Polyglactin. So it is copolymer of This is copolymer of G glycolide, lactin, lactide. Clear? So it is copolymer of glycolide and lactide. Clear? It is delayed absorbable suture. So it is a delayed absorbable suture and its tensile strength is maintained for 28 to 30 days. So its tensile strength is maintained. This is maintained for 28 to 30 days. Clear? Okay. And if you have seen general surgeons, especially in OT, whenever we are operating or doing some kind of laparotomy, resection, anastomosis, generally general surgeons are shouting for a suture. Which suture? Vicryl, 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 vicryl. So this is the suture which is considered as workhorse suture for general surgeons. So vicryl is the workhorse suture for general surgeons. Simple. Now, there is one important question, that the organs in which there is stone formation tendency, like bile duct, ureter, bladder. So the organs in which there is stone formation tendency are the organs in which stones are formed. If we are supposed to use the suture for those organs, which type of suture should be used? It should be absorbable suture or non-absorbable suture. So obviously we cannot use non-absorbable sutures for these organs like CBD, ureter and bladder, because if you are using non-absorbable suture, what will happen? It will act as a nidus. And what will happen? There is stone formation. That's why in these organs we are using absorbable suture. And what kind of absorbable suture? Delayed absorbable suture. And which one? Vicryl. So generally this vicryl is used for these organs. So vicryl is a delayed absorbable suture. That's why it is used in CBD. It is used in ureter. It is used in bladder, right? So how to remember? The mnemonic is cub. So mnemonic is cub. Clear? So it is CBD, ureter and bladder. Now see this image and you can see on this packet what is written? Monocryl. So this is monocryl, and monocryl is also known as polyglycaprone. So the name of this suture is monocryl, and it is also known as polyglycaprone. Clear? So poly, it means it's a copolymer of what? Gly. Here how to remember? Glycolide and plus caprone. So this is caprolactone. So it is the copolymer of glycolide and caprolactone. Clear? This was the image based question asked in AIIMS. And what was the question? That which of the following suture is used for subcuticular suturing? So this is the suture which is used for subcuticular suturing, and this monocryl is absorbed in 90 to 120 days. So two important questions. It is used for subcuticular suturing. Subcuticular suturing. Clear? And it is absorbed in 90 to 120 days. Next is polyglycolic acid. Polyglycolic acid. Okay, the suture, and this is also known as Dexon. Clear? So first, it is polymer of polyglycolic acid. So this suture is polymer of polyglycolic acid, and we discussed that polyglycolic acid is a polyfilament suture. Now the problem, we discussed that in polyfilament sutures there is increased risk of infection, and especially what is the big problem with this suture, especially that this suture exhibits highest affinity for adherence to E. coli and Staph aureus. This suture exhibits highest affinity for adherence to E. coli and Staph aureus, and you must be knowing that this E. coli and Staph aureus are two important pathogens responsible for infection in surgery, right? So what is the biggest problem with this suture, Dexon? That first, it's a polyfilament, that's why there is increased risk of infection, and the second problem, there is highest affinity. Suture is having highest affinity for adherence to E. coli and Staph aureus. Clear? And this suture is absorbed in 60 to 90 days. So suture is absorbed in 60 to 90 days. So what are the two important questions which are asked? That this suture, Dexon, is having highest affinity for adherence to E. coli and Staph aureus, and it is absorbed in 60 to 90 days. Now there is a suture which is having lowest affinity for adherence to E. coli and Staph aureus, and that suture is absorbed in 180 days. And what's the name? This is PDS, also known as polydioxanone. Now see, this is polydioxanone, also known as PDS. Clear? Important point, that this suture is having lowest affinity for adherence to E. coli and Staph aureus. So one advantage, it is associated with lesser risk of infection. And what is the second advantage? That it is absorbed in 180 days. It means this suture is specifically used for those anastomoses where there is increased risk of anastomotic leak. So if you remember Whipple's procedure, in Whipple's procedure we discussed that at pancreaticojejunostomy, which anastomosis? Pancreaticojejunostomy is having maximum risk of anastomotic leak. So at pancreaticojejunostomy, which suture we use PDS, right? So it is absorbed, you have to remember, absorbed in how many days? 180 days. Clear? And that's why it is used in Whipple's procedure, especially for which anastomosis? We use it at pancreaticojejunostomy, at PJ. Now see, what's the name of this suture? Can you see here? It's proline and it's written polypropylene. So the name is proline. It is also known as polypropylene. Okay. It is monofilament or polyfilament. So it is monofilament. Absorbable or non-absorbable suture? So this is non-absorbable suture. So this is monofilament and it's non-absorbable suture. Clear? Now you can see here that one artery forceps is being applied here. If you have seen that whenever we are using proline, especially you have seen it during suturing of rectus sheath in laparotomy, so you notice that at one end of the suture mosquito forceps are being applied. So why we apply the mosquito forceps? Because this suture is having very strong memory. What is the meaning of memory? Memory means tendency to return to its unpackaged state. So what are the problems or disadvantages of this suture, proline? That it is having strong memory, it is having poor knot security. So strong memory, there is poor knot security, and there is lack of elasticity. Lack of elasticity. Clear? These are the disadvantages. But we want to convert disadvantages into advantages, right? So since there is lack of elasticity, right? So we can use this suture for airtight anastomosis, and the airtight anastomosis is required where? It is required in cases of vascular anastomosis. So this suture is used for vascular anastomosis, and this question was asked in NEET. So what are the uses of Prolene? We discussed that it is used in vascular anastomosis because it can create watertight anastomosis, and second, we use Prolene for rectus sheath. So these are the important questions related to sutures. Now two questions which are frequently asked, that which suture is absorbed in how many days and at this particular site, and in this particular anastomosis which suture is used. So see the questions. So first, sutures which are absorbed in 60 days. So we discussed which suture is absorbed in 60 days. Yes, it's the catgut. Second is 60 to 90 days. So the sutures which are absorbed in 60 to 90 days, and the mnemonic is VCD. Clear? So we discussed V, vicryl, C, chromic catgut, D, dexan, and the other name of dexan is polyglycolic acid. So this is vicryl, this is chromic catgut, and D, this is the dexan, also known as polyglycolic acid. Then 90 to 120 days. Clear? So we discussed monocryl, also known as polyglycaprone. So monocryl, also known as polyglycaprone. And what was the question we discussed? That this monocryl is used for subcuticular suturing. And 180 days we discussed just now. Which suture is absorbed in 180 days? And this is PDS, also known as polydioxanone. Now see the site and the uses of suture. So generally for skin suturing, which suture is used? Silk. So see, silk. What is the use of this silk suture? Generally we use it for the skin. We discussed what is the use of vicryl, and we discussed the mnemonic also. It is used in the organs where there is stone formation, and the mnemonic was cub. C means CBD, U means ureter, B means bladder. So this is CBD, ureter, and bladder. Clear? Then we discussed Prolene. What's the use of Prolene? It is used for vascular anastomosis. And what else? It is used for suturing of rectus sheath. So this is used for rectus sheath. Simple. And for tendons, which suture is used? For tendons we use nylon, right? So nylon is used for tendons. Now if you have seen the question of AIIMS and NEET, nowadays they started asking the suturing principles also. Means suppose you are going to perform the laparotomy, right? And you are going to give any kind of skin incision, and suppose the length of incision is X, what should be the length of suture? So this is known as Jenkins rule, right? So one by one we are going to discuss the important points related to suturing. So first, what is the Jenkins rule? Clear? So if the length of incision is X, what should be the length of suture required? 4X. It means is the ratio of suture length to wound length. So ratio of suture length to wound length, and this should be 4:1. Now suppose there is elliptical incision. So this is the elliptical incision, and you want that the healing should occur without tension. And if the width of this elliptical incision is x, the width is x, what should be the length of incision? So it should be 3x. So for elliptical incision, you want that healing should occur without tension. So the length to width ratio should be 3:1, right? So second important question, for elliptical incision to heal without tension, length to width ratio should be 3:1. Now see, whenever we are going for skin suturing, imagine that you are going for skin suturing after laparotomy, and these are the sutures which are being applied. Can you see? These are the sutures. Clear? And see, this is the thickness of skin. This is the skin thickness. Skin thickness is x. If the skin thickness is x, what should be the distance between the sutures? Yes, so it should be 2x. So for skin suturing, what is the ratio of distance between the sutures to the skin thickness? So here you can see the skin thickness is x and the distance between sutures, this is 2x, right? So for skin suturing, the ratio of distance between sutures to skin thickness, and that should be 2:1. Clear? So it is very easy to remember. According to Jenkins rule, suture length to wound length ratio 4:1. For elliptical incisions to heal without tension, length to width ratio should be 3:1, and for the skin suturing, distance between sutures to the skin thickness ratio should be 2:1. Now we are going to discuss the types of knots, okay? And these are being asked in AIMS as well as NEET from the last 3-4 years continuously. Now see, first is square knot or reef knot. So see how we are going to take square knot or reef knot. See, this is the cable and this end is laptop end, which is connected to laptop, and this is the phone end. Okay, now see what I'm going to do in this case. I'm going to take the first throw, right? And can you see now the laptop end comes in my right hand? So what I did, in first throw I crossed, okay, and after that what I'm going to do in the second throw, again I'm going to cross. Clear? So now the laptop end comes into my left hand. Okay, this is the square knot or reef knot. And if you see what happens here, can you see the both ends are together, and here also you can see the both ends are together. So this is square knot or reef knot. So what we did, in first throw we crossed, in second throw also we crossed. So this is relatively stable knot. So this is square knot or reef knot. How many throws we are going to take? So this is the first throw and this is the second throw, and in each throw we crossed. So we take 2 throws. Crossing is done in each throw. Crossing is done in each throw. Clear? And this is relatively stable knot. This is relatively stable knot. Okay, how to identify? It's very easy to identify. See, if you see the ends, can you see here the ends are together? Can you see here the ends are together, right? So here you see both ends are below, and here both of these ends are above. So here you can see, if you see the ends which is of red color, yes, that is above the blue, and here you can see the ends which are of blue color, these two ends are below the red. Clear? So if both ends are together either above or below, this is square knot or reef knot. Second is surgeon's knot. Surgeon's knot is also very easy to identify. Now see, this is the laptop end and this is the phone end. Okay, now in first throw, can you see I'm taking the first wrap and then I'm taking the second wrap. So how many wraps are taken in first throw in surgeon's knot? Can you see we took 2 wraps, clear? And after that, in second throw, again I'm going to cross, and how many wraps? Single. Okay, so in first throw you can see 2 wraps, in second throw 1 wrap, and in both throws we are going to cross. So this is what? Surgeon's knot. So here you can see this is surgeon's knot. So there are 2 wraps in first throw, 2 wraps in first throw, right? So you can see this is 1, this is 2 wraps, and we have to cross. And in second throw there is a single wrap, so 1 wrap in second throw, clear? And crossing is done in each throw. So in surgeon's knot, crossing is done in each throw. Clear? Now third is granny knot, also known as pseudo square knot. Okay, now see, this is the laptop end, this is a phone end. What I'm going to do, I'm going to take, can you see, I'm going to take here, I'm going to take the first throw, and again you can see the phone end comes in my right hand. Clear? Means I didn't cross. After that, again I'm going to take what? The second throw, and here also I'm not going to cross. Clear? So I didn't cross. So in this 2 wraps are there and crossing is not done. And if you are going to see the ends, see here carefully, if you see the ends, one end is above and one end is below. Can you see here? So the ends are not together. Can you see? The ends are not together. So this is granny knot or pseudo square knot. And granny knot or pseudo square knot is not a very stable knot. So this is granny knot, also known as pseudo square knot. Pseudo square knot. Clear? And you saw that how many throws are there? We take 2 throws. Clear? But crossing is not done. And since crossing is not done in any throw, so it's relatively unstable. So this is relatively unstable and it's more prone to slip. Right? It's more prone to slip. Now how to identify? It's very easy. See, one end is above and one end is below. So both ends are not together. See the colored picture? So if you see this colored picture, you can see that this end, which is of red color, yes, one is below this blue and one is above this blue color. Okay? And here you can see the end which is of blue color, one is above and one is below. So how to remember? If these are the ends, if ends are together either above or below, the knot is stable, and that is reef knot or square knot. And if it's like this, what, one end is above and one end is below, it means it's not very stable, and this is granny knot or pseudo square knot. Now let's see all the 3 together, how to identify and how to differentiate. Easiest is surgeon's knot. Why? Because in first throw we are going to take how many wraps? 2 wraps. So if there are 2 wraps in first throw, generally this is surgeon's knot. Now see, if there is 1 wrap, if crossing is done, yes, it is reef knot or square knot. If crossing is not done, it is granny knot. How to identify? See the edges. If the ends are together, it's square knot or reef knot. If ends are not together, it's granny knot. So you can easily crack any image based question related to the knots. Now we are going to discuss the needle. First, what are the parts of needle, and then we will discuss what are the types of needle. Okay, see the parts. You can see here the suture is being attached to the needle, and this end is known as swaged end. In the needle where suture is attached, that is known as swaged end, and the opposite end, which is pointed, and that is known as pointed end or point, and this is known as body or shaft. Sometimes in the needle you will notice that there is an eye. So there is a hole known as eye, and via this eye I am going to insert the suture. Clear? So these are the parts of needle. Now the question, where we are supposed to hold the needle with needle holder. So you can see this is 2/3 from pointed end and 1/3 from switched end. So where you are supposed to hold the needle with needle holder at the junction of 2/3 from the pointed end and 1/3 from the switched end. Now see the types of needle. Broadly we are going to divide the needle into two types. One is round body and second is cutting needles. Cutting needles can be conventional cutting or reverse cutting. So see the types of needle. Needles can be round body or cutting. Clear? This cutting is further divided into conventional cutting. It's conventional cutting. Clear? And second is reverse cutting. Reverse cutting. Okay. So it's very easy to remember. Suppose this is the needle. Clear? And what you do, you take the cross section, and if you see the cross section here, the cross section appears round. So if the cross section is round, it's round body, and if it's triangular, it's cutting. Now in conventional cutting, the cross section is like this, and in reverse cutting, the cross section is like this. It means in conventional cutting, the cross section is triangular with apex, can you see apex pointing inwards, and in reverse cutting the apex is pointing outwards. Okay. Now round body needles are further divided into round body needles. Can you see the cross section is round? Clear? So round body needles are circular. So these are further divided into taper point and blunt point. Okay. Now see the point of needle or pointed end of needle. If you see this pointed end of needle, if it is tapering, if the pointed end of needle is tapering, clear, this is taper point, and if it's blunt, can you see, if it is blunt, it is known as blunt point. So round body needles are further divided into taper point if the end is tapering, and blunt point if the end is blunt. So we discussed the cutting needle, conventional cutting and reverse cutting. So here you can see the cross section is triangular, but in conventional cutting it is pointing inwards. Can you see, pointing inwards, and in reverse cutting, can you see, it is pointing outwards, right? Now the basic difference, you saw this round body needles are non-traumatic, and if round body needles are non-traumatic, generally these needles are used for delicate structures. So what are those delicate structures? Bladder and bowel. And these cutting needles, these are traumatic needles. So what is the advantage? That these needles are used to pierce the tough structures like skin, sheath, fascia. Okay, so one by one we are going to discuss. Round body needles, these are non-traumatic, and since these are non-traumatic, we are going to use these needles for delicate structures. And what are those delicate structures? So we are using these needles for bladder and bowel. It is used for bladder and bowel. Okay. Now cutting needles. Cutting needles are traumatic. These needles are traumatic, right? And that's why these needles are used to pierce tough structures. So we are using these needles for tough structures, right? Like skin, sheath and fascia. Skin, sheath and fascia. Now we are going to discuss the suturing techniques. Okay. Now see, first, simple interrupted suture. So first is simple interrupted suture. How we do it and how to identify in exam. Now here you can see this needle is inserted at right angle to the incision. Right angle, it is going to pierce the edge, and after that it is going to pierce the second edge, and again it comes at right angle. So what is this? It is going to pierce the skin of incision at right angle, going to traverse both the edges, and it is coming out or it is going to exit again at the right angle. Clear? And when we are going to come out, we are going to apply the knots. Clear? So can you see here? Needle is inserted at right angle to the incision, traverses both of the edges, and then exit again at the right angle. So if you see, this is the skin incision. Clear? Now I'm going to pierce it at right angle. Clear? And again this needle is going to pierce, and then it is going to come out at right angle, and after that the knots are applied. Clear? So this is simple interrupted suture. So here needle is inserted at right angle to the incision, inserted at right angle to incision, then it traverses or pass through both edges of wound. Clear? So it passed through both edges of wound and then exit again at right angle. Clear? So this is simple interrupted suture. Now see the continuous suture. What we do in this case? So the name is continuous. So here the first suture is just like simple interrupted suture. Okay, and rest of the sutures are taken continuously until the far end is reached. Have a look. So here I'm going to take the first suture, which is simple interrupted. Clear? And after that what I'm going to apply it like this. So can you see? Rest of the sutures are applied continuously. So here it's like this. So the rest of sutures are applied continuously until the far end is reached, and when the far end is reached, we are going to tie the far end by Aberdeen knot. So how it looks like? So see this continuous suture. Here the first suture is like simple interrupted suture, and then you can see I'm going to take the suture. Can you see? And the suture is being taken continuously until the far end is reached, and when we are reaching the far end, here we are going to tie the knot or secure the knot with Aberdeen knot. Clear? So what's done in this continuous suture? Here the first suture, this is identical to simple interrupted suture. Clear? And rest sutures are continuous. Rest of sutures, these are taken continuous until the far end is reached. Clear? And the far end is secured with Aberdeen knot. So far end, this is secured with, it is secured with Aberdeen knot. Clear? So what happens here? You can see this is Aberdeen knot, and what we do in this Aberdeen knot, here you can see we tie. So here we are going to tie free end to the loop of last suture. So tie free end, can you see here? Free end to the loop of last suture. Clear? And what is the example you have seen in laparotomy? When we are suturing the rectus sheath with the proline, generally we take the continuous suture. Now third is mattress suture. Mattress suture. Okay, these are frequently asked nowadays, especially in NEET and AIMS. See, sometimes because of trauma or because of musculoskeletal trauma or soft tissue injury is there, and what happens? The wound edges are not approximated. Clear? And it's difficult to approximate the wound edges because these are irregular. So whenever there is irregularity in depth or disposition of wound edges and we have to approximate it, we can use the mattress suture. If we have to invert or evert the edges, we use the mattress suture. Okay, So what is the use of mattress sutures? So it is used for eversion or inversion. Eversion or inversion of wound edges. Clear? And it helps in accurate approximation of wound edges. So it helps in accurate approximation of wound edges, and especially for which wound edges? The wound edges which are irregular in depth or disposition. So for which wound edges which are irregular in depth or disposition. Now two types of mattress are there. One is horizontal mattress and the second is vertical mattress. Okay, it's very easy to remember and it's very easy to differentiate. Now if you see, the first one is horizontal mattress and the second is vertical mattress. Okay, what's the difference? See, this is horizontal mattress, right, and this is the vertical mattress. Okay, now see how we are going to take the horizontal mattress first, right? Now see, I'm going to pierce the skin edges, clear, like this at right angle. So generally the initial suture is taken as a simple interrupted suture. So what? The needle is going to pierce both of the skin edges at right angle. Now when this is taken out, can you see here, when it's taken out, this needle moves horizontally, can you see? And again it is going to pierce the wound edges, clear, and then knots are tied. So here needle moves horizontally and traverse both edges of the wound again. So since it is traversing horizontally, this is horizontal mattress. And what happens in vertical mattress? Can you see here, I'm going to pierce the both edges of wound at right angle, just like simple interrupted suture, and then you can see the needle moves vertically and again it is going to pierce both edges of the wound. So here the needle moves vertically, so this is vertical mattress, right? So first is horizontal mattress and second is vertical. Here in both initial suture, it's like, or it's made like simple interrupted suture, clear. In horizontal mattress, needle moves horizontally, needle, can you see here, needle moves horizontally, in vertical mattress, can you see, it moves vertically. So needle moves horizontally in horizontal mattress, and in vertical mattress it is going to move vertically and then again traverses both edges of wound again. So here it traverses both edges of wound again, clear. So this is horizontal mattress and vertical mattress. Now easiest method how you can identify or crack the question easily in exam if it's an image based question. You can see this is the line of incision, this is the line of incision, and if you see the horizontal mattress, in horizontal mattress, yes, it is parallel to line of incision. So in horizontal mattress the suture is parallel to line of incision, and if you see the line of incision in vertical mattress, it is perpendicular to the line of incision. So this is how you can easily identify the horizontal and vertical mattress. So now see how we take horizontal mattress. Can you see the needle is going to pierce the both edges of the wound, clear. So just like interrupted suture, now can you see the needle moves horizontally, and if needle moves horizontally and I'm going to tie the knot, this is horizontal mattress. And see if the needle is going to move vertically, here can you see the needle is going to move vertically, so this is vertical mattress. Now see subcuticular suture, subcuticular suture. Now in this image, can you see, you can see only the ends, Rest of the suture, can you see the rest of the suture is buried under the skin? So this is subcuticular suturing, and we discussed that for this subcuticular suturing, which suture is used? It's monocryl or polyglycaprone. What is the advantage of this subcuticular suturing? That there is no scar. Clear? So generally this subcuticular suturing or subcuticular suture is used for cosmetic areas, right? So the most commonly used suture is the monocryl, also known as polyglycaprone. Clear? And it is specially used in the skin where cosmetic appearance is important. Cosmetic appearance is important. Okay, what is a prerequisite here? That here the edges should be approximated. So the skin edges should be approximated, then only we are going to take the subcuticular suture. Now see this image. What kind of wound is here? Can you see? There is a circular wound. Can you see? There is a circular wound, and if you see the suture, you can see that here the suture is applied parallel to edges of the circular wound. So when the suture is applied parallel to the edges of circular wound, and when you are going to tie it, it is just like purse string. So this is known as purse string suture. You have seen the purses basically which were distributed in 90s, especially in the marriages, red colored purse, and there was a string like this. So this is what purse string suture. Clear? So here you noticed what is done. Basically in a circular wound, the suture is applied parallel to the edges of wound. Parallel to edges. Clear? Now what is the use of this purse string suture? We discussed in hernia surgery, when we were performing herniatomy, we were taking the purse string suture, and then only, can you see, this was the sac, and we were applying purse string suture like this, and then we were excising the sac, redundant sac. Second, in appendectomy also we take purse string suture. So in surgery, what is the role of purse string suture? It is used in herniatomy or hernia surgery, and second, it is used in appendectomy. Clear? So these are the important types of suturing techniques. Now what are the guidelines for day of suture removal? Means on which particular day sutures should be removed. It varies from one side to another. Clear? So see the area and day of suture removal. Day of suture removal. Clear? So in eyelids and lip, generally the suture should be removed on 3rd to 4th day. So eyelids and lip, it is removed on 3rd to 4th day. Right? Now in eyebrows and nose, it should be removed on 3rd to 5th day. Eyebrows and nose, it should be removed on 3rd to 5th day. Clear? And if you see the rest of face excluding ear, generally the suture should be removed on 3rd to 4th day. So rest of face, 3 to 4 days. Clear? So roughly what you noticed, that generally in face we are supposed to remove the sutures on 3rd to 4th day excluding ear. In ears we are going to remove the sutures on 10th to 12th day. Now see, in scalp the sutures are removed on 6th to 8th day. So it should be removed between 6 to 8 days. Similarly in chest and abdomen, 8 to 10 days. So chest and abdomen, it should be removed in 8 to 10 days. Clear? And if you're talking about ear and hand, and see, in ear and hand the sutures are removed in 10 to 14 days, right? So in ear and hand the sutures are removed in 10 to 14 days. Clear? And if you see back, extremities, foot and sole, in back, extremities, foot and sole, here the sutures are removed in 12 to 14 days, right? So back, extremities, foot and sole, here we remove the sutures in 12 to 14 days. Clear? Now how you can remember it easily? We discussed that face related area, okay, except ears. Clear? So in face generally the sutures are removed in 4 days. So broadly we are removing the sutures in 4 days. Clear? In scalp, in chest and abdomen it is removed in 8 days broadly. So how to remember? 4 into 2. So in scalp, chest and abdomen it is 4 into 2, 8 days. So here it is 4 into 2. Clear? And in rest of the regions, can you see? In ear, hand, back, extremities, foot and sole, it is 4 into 3 in what? 12 days. Clear? So this is the easiest way to remember. Now we are going to discuss the bowel anastomosis. But before discussing bowel anastomosis, I want to tell you the layers in the bowel. See? So here you can see this innermost is mucosa. Okay? Then this is submucosa. Clear? And these two layers are of muscularis propria. And you must be knowing that in muscularis propria there is inner circular layer and outer longitudinal layer. Clear? And this outermost is serosa. Right? 2-3 principles which we follow in bowel anastomosis. First principle, that whenever we are doing the bowel anastomosis, you have to include the submucosa. Why? Submucosa is having high collagen content. Clear? And it is the strongest layer of bowel. That's why it should always be included in the suture. So during anastomosis you have to take the submucosa in anastomosis. 1. And in bowel anastomosis the anastomosis should be inverted to prevent the risk of leak. Clear? So 2 important principles which we follow in bowel anastomosis. First, that the edges should be inverted. So there should be inverted edges, and we have to include submucosa into anastomosis. So in anastomosis, when we suture, we have to include the submucosa because of its high collagen content, and this is the strongest layer. Now what are the types of bowel anastomosis? It can be single layer, it can be double layer, or stapled anastomosis. Clear? So one by one we are going to discuss. Initially we were favoring double layer anastomosis, that is known as Cocker's 2-layer anastomosis, but nowadays single layer extramucosal anastomosis is preferred. So first see single layer extramucosal anastomosis. Single layer extramucosal anastomosis. Clear? See the peak. So this is Halsted favored, Matheson advocated. This is Halsted favored, Matheson advocated. Clear? Now see what is done here. Here you can see this is mucosa. So here the mucosa is not taken. right? And rest all the layers, submucosa, muscularis propria, serosa, all the layers are taken in one layer. So that's why this is known as single layer extramucosal anastomosis. And this question was asked in NEET PG, that nowadays which type of bowel anastomosis is preferred is the single layer extramucosal anastomosis. This is preferred for bowel anastomosis nowadays. It is preferred for bowel anastomosis. Clear? Initially, we used to do Cocker's two-layer anastomosis, but nowadays single-layer extramucosal anastomosis is preferred. Now see this. This is Cocker's two-layer anastomosis. So here, it's Cocker's two-layer anastomosis. Okay. Now see, what is the first layer? If you see, this is the first layer. And what is the name of first layer? This is known as Albert layer. Initially, we were using catgut. Clear? So first layer, we were using catgut. Other name, this is Albert layer. Clear? So in this, we were using catgut continuously. So this is also known as continuous catgut layer. But nowadays, at the place of catgut, we are using vicryl. So what is the other name? This is also known as continuous catgut layer. Right? And what's the change? Nowadays, at the place of catgut, we are using vicryl. So in first layer, what we use? The vicryl. And the second layer is Lambert layer. And this is interrupted silk layer. So you can see here, this is the second layer. This is the second layer. And that is also known as Lambert layer. Lambert layer. Clear? And this is also known as interrupted silk layer. So here we are taking silk or using silk for suturing. Clear? Initially this was favored. This is Cocker's two-layer anastomosis, but nowadays we favor single layer extramucosal anastomosis. The third type is stapled anastomosis. And for stapled anastomosis, we use two types of stapler usually. One is linear stapler and one is circular stapler. Okay. So see which one is linear stapler, which one is circular stapler. Now here you can see this is the linear stapler. Okay. And how we are going to use this linear stapler? So if you see this image, suppose these are the two ends of bowel. Okay, so I'm going to insert one limb into one part of bowel, second limb into another, and after that I'm going to fire the stapler. When I'm going to fire the stapler, what will happen? There is communication. So what happens? It is going to create the side to side anastomosis. Can you see? So here, this linear stapler is going to create the side-to-side anastomosis. Still, these ends are open and these ends are closed with the help of transverse stapler. Can you see? So here, these ends are being closed with transverse stapler, right? So what is the use of this linear stapler? It is used to create side-to-side anastomosis. Side-to-side anastomosis. Clear? And in this case, ends are closed by transverse stapler. Transverse stapler. Right? Now, what is the use of this circular stapler? This is circular stapler. Generally, this circular stapler is used for end-to-end anastomosis. Clear? So generally in which cases end-to-end anastomosis, especially the colorectal anastomosis, coloanal anastomosis. So whenever we are going for low anterior resection and we go for end-to-end anastomosis of bowel, we are using circular stapler. Even in stapler hemorrhoidopexy, we are using the circular stapler. So here you can see how we are using this circular stapler for end-to-end anastomosis. Clear? So circular staplers are used for end-to-end anastomosis, and generally where we are using these staplers in surgery, we are using it in low anterior resection and stapler hemorrhoidopexy. We are using it in stapler hemorrhoidopexy. Clear? So these are the stapled anastomosis. So this is all about sutures and anastomosis.